You're listening to Medscape's In Discussion series on cancer survivorship, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathryn J. Ruddy. Dr. Ruddy is a professor of oncology at Mayo Clinic who provides medical oncology care to patients with breast cancer. In addition to her clinical activities, Dr. Ruddy co-leads the Mayo Clinic Comprehensive Cancer Center Cancer Prevention, Control, and Survivorship Program, and she is active in research focused on the prediction and prevention of toxicity in patients with cancer, as well as patient-reported outcomes during and after cancer treatment. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for use healthcare professionals.
Hello, I'm Dr. Kathryn Ruddy. Welcome to Season 3 of the Medscape In Discussion Cancer Survivorship podcast series. Today we'll discuss the importance of screening for and treating pain in cancer survivors, both during and after cancer therapy. First, let me introduce my guest, Dr. Andrea Cheville. Dr. Cheville is a professor of physical medicine and rehabilitation on Mayo Clinic's Rochester campus. Dr. Cheville, welcome to the Medscape In Discussion Cancer Survivorship podcast.
Thank you so much, Dr. Ruddy. It's an incredible pleasure to be here.
We're thrilled that you could join us. And I want to start out by asking you to tell our audience about some of the common causes of pain in cancer survivors.
Well, I suspect that many members of the audience will be familiar with residual cancer pain due to the presence of tumor. And perhaps we won't focus as much on that today because I think perhaps most oncologic professionals and clinicians are versed in that. I think what is an important topic is the amount of musculoskeletal pain that we've discovered in cancer survivors, as well as durable sequelae from cancer treatment, chemotherapeutic neuropathy. Some patients, if they've had large resections or tissue transfers for wound management, may have pain at those sites, both neuropathic and musculoskeletal. It's not uncommon that when we fix a segment of the skeletal system by sclerosing a joint, by stabilizing the spine, then other segments of the muscular system may become hypermobile and cause pain in the future. And so an important dimension of pain control in the survivorship population is in many ways anticipatory, trying to not wait until the patient develops pain, but identifying vulnerabilities and proactively addressing those.
When you say proactively addressing, what are the strategies that can help in this setting to help prevent issues?
Sure. One is to ensure maintenance of range of motion and flexibility in all segments of what we would call the kinetic chain, which is essentially the leg bone is connected to the hip bone. But we want all of the musculoskeletal components to interact fluidly and with optimal biomechanics. So we want to make sure that patients don't develop radiation-associated contractures. So range of motion in what we would call within physiologic limits is critical to maintain and much easier to maintain than restore once a patient becomes contracted. Another is maintaining optimal posture. Sometimes if patients become sarcopenic or because they're temporarily in pain, they develop suboptimal ways of moving or holding themselves. And those are very remediable, but again, easier if we do that sooner than later. One common example is patients may develop tightness in the pectoral muscles and develop a bit of a thoracic kyphosis, that dowager's hump, which can cause their cervical spine to hyperextend. And all of those subtle adjustments can foster pain, whether it's a rotator cuff tendinopathy or a cervical radiculopathy. When we start to move away from optimal alignment, risk increases for some of these musculoskeletal sequelae. So you ask a straightforward question, and I'm elaborating, but range of motion, maintaining strength, maintaining endurance, identifying sources of pain, and if they're durable, so not transient, trying to identify a definitive pain generator and delivering diagnosis-driven and appropriate treatment. Certainly, you're an oncologist. Efforts to mitigate neuropathy is one, but that's a little outside the wheelhouse of the physiatrist.
I've heard you talk about pain generators before, but could you, for our audience, explain a little bit more about what you mean by that?
Absolutely. When we talk about a pain generator, and I'm going to restrict my comments to the musculoskeletal system and the neuromuscular system, an example would be if somebody has back pain, it's back pain, but it may be because they have arthritis in a facet joint or an inflamed facet joint. It may be because they have some central canal stenosis. It may be because there is a spastic muscle or an overloaded muscle. They may be pinching a nerve. It could be at the foramen where the nerves exit the spinal cord. Those would be pain generator, discrete, usually anatomically defined areas that, because of inflammation or trauma or compression, the nociceptive system is being stimulated. And we can certainly, a lot of palliative care is in parallel to identifying a pain generator and eradicating that when we can. A lot of palliative care is simply palliating. We don't get so hung up on exactly what's causing the pain, but rather the pain becomes our focus. And we may use opioids and other analgesics to reduce the pain. But when we're in a diagnostic framework, always we're trying to identify a pain generator and, if possible, definitively treat it.
Is there a role for integrative medicine in treating pain in this setting?
Oh, absolutely. I think so many integrative modalities, whether they're body-oriented therapies, massage, Reiki, yoga stretching, and restorative yoga approaches, and the list goes on and on. They certainly can be very effective in reducing muscle tone. So having pain from muscle spasms is quite common among cancer survivors. So certainly integrative modalities are excellent in that way. They can improve sleep quality, reduce anxiety. So many of the things that can trigger and perpetuate a pain syndrome are responsive to integrative care. Certainly, people use acupuncture, Tai Chi can be beneficial when we identify a pain generator. So I think both when we're talking about holistic wellness as well as generalized pain mitigation and also very focal treatment, integrative modalities can have a very important place.
That makes perfect sense. And I wonder if you could tell our audience a bit about your very important recent E2C2 trial, which you presented at ASCO last year, and contextualize that related to pain management. I'm wondering if the findings of E2C2 have changed the way you think about pain management and the role of PM&R in patients with cancer.
Very much so. The E2C2, which stands for EHR Facilitated Enhanced Cancer Symptom Control, was a pragmatic cluster randomized stepped wedge trial that was deployed at the population level throughout the Midwest Mayo Clinic medical oncology practices. And it involved using EHR embedded patient reported outcomes. We used a simple 0 to 10 rating scale and assessed 5 symptoms in physical function. And pain was one of the symptoms, as well as sleep, anxiety, depression, and fatigue. And the goal was to screen longitudinally for these symptoms. And if a patient endorsed a moderate level of a symptom, which we operationalized as a level of 4 to 6, or a severe level, which would have been 7 to 10, we offered them what we would call stepped care. So in the case of if it was moderate pain, we provided self-management approaches. If it was severe pain, the option to work with what we called a symptom care manager. And for some pain and loss of physical function, that was a physical therapist. We used a very well-validated approach called the collaborative care model, in which a dedicated team serves the patient, but in parallel also serves the medical oncology team to assist them in managing and initiating multimodal pain care, which can involve rehabilitative and integrative elements. And so what we found was that deploying this at the population level, it achieved not only significant reductions in symptoms, but it also reduced utilization by as much as 30-fold. And the utilization outcomes were ICU visits or admissions, ED visits, and hospitalizations. And I think in my mind, one of the big take-homes is the importance of continuous monitoring and apprising patients that symptoms are normal in the context of cancer, that they're treatable, and it's important to treat them proactively, and offering a lot of validation and reassurance. Many patients don't know how to make meaning always from their symptoms. In the E2C2 cohort was clearly a subgroup of patients that had persistently high symptoms and worked on multiple occasions with symptom care managers and seemed to have benefited disproportionately. And clinical experience bears this out. There seems to be a cohort, maybe it's roughly 15% of patients, that are severely affected, both from pain but also loss of physical function, that really benefit from this kind of a hypervigilant model assessing their symptoms. But it also emphasized the importance of giving patients agency in determining whether and when to engage with symptom-directed care, and also in selecting what types of analgesia they were interested in. It was, I think, heartening and surprising to find out how many patients were much more interested in receiving movement-related and activity-related approaches to control several symptoms, fatigue as well as pain. Many were quite ambivalent about using additional medications. And so I think it argued very effectively for patients' interest and the need, if we're going to serve our patients well, that we ensure we make these modalities available to them.
That's such a great point. And I'm sure informed your development of your next trial, the ASCENT trial that you're conducting currently. I'm sure our audience would enjoy hearing a little bit about how you're specifically focusing on pain management here within ASCENT.
Sure. The ASCENT trial was very much a byproduct of the E2C2 study. And E2C2 study was funded through the Bo Biden Moonshot Initiative at the National Cancer Institute, and we're incredibly appreciative for that support. The ASCENT trial is also funded by NCI, and it seeks to address durable disparities in pain management among Hispanic and rural dwelling cancer survivors. It also is based on the collaborative care model, but it differs in that we added a community health worker to the team and expanded the focus of the interventionalist to include social determinants of health, recognizing that access to key elements of what we would call multimodal pain care are not consistently available to these populations. And multimodal pain care simply refers to the combination of different analgesic approaches. That could be medications, it could be integrative modalities, cognitive behavioral approaches, as well as movement approaches to treat a patient's pain, and to do that per their past responsiveness and preferences. So the ASCENT trial is examining the effectiveness of an expanded collaborative care team that engages or includes a community health worker to address social determinants while working remotely. So it's, in a sense, geography agnostic, remotely with patients to develop and refine personalized pain management programs with a strong emphasis on non-pharmacologic-based approaches. We've now crossed the halfway point in recruiting our target sample of 660 patients. So hopefully we'll have results of that in a few years.
You mentioned pharmacologic approaches. Can you talk a little bit more about what those are? And also, are there stigmas that are related to pain medication that are impeding good pain care? And are there ways we should be addressing these?
Yeah, that's such an important question. We have non-opioids, which would be acetaminophen or Tylenol, non-steroidal anti-inflammatories. Then we have what we would call adjuvants or co-analgesics. And these are usually agents that have other applications beyond pain management, but cross the blood-brain barrier and influence nociceptive transmission or nociceptive modulation. So these are medications, commonly gabapentin, pregabalin, duloxetine, some of the SSRIs, SNRIs. Some antipsychotics have analgesic properties. Certainly the tricyclics, steroids can be co-analgesics or adjuvants. And then we have the opioids. And that's certainly a group of medications that are very efficacious for many patients. However, when used over time in an unmonitored and potentially inappropriate fashion, may cause addiction and other harms. And as a society, we've learned that quite painfully during the opioid crisis. Unfortunately, the message that opioids inevitably and inexorably lead to addiction has gained traction, and many patients hearing that are reluctant to take them, even though for those with diffuse cancer, with bone metastases, with visceral metastases, often opioids are the evidence-based and the guideline recommended treatment approach. And so it's certainly important to explore patients' attitudes towards opioid. And not a trivial number of our patients have had relatives with addiction issues, have had opioid dependence, may even have lost loved ones through opioid addiction. And so the beliefs can be very entrenched. And I think it's important for us as providers, in order to deliver adequate pain control, to explore these potential barriers and attitudes, which are not obviously ungrounded, but may be held too rigidly and undermine patients' capacity to achieve pain control.
Are there other barriers to good pain care in the United States beyond these stigmas?
I wish I could say no, but absolutely. I think access and coverage for integrative approaches remains a major challenge. Medicare is, I think, a very constructive response to the opioid crisis, is beginning to cover more validated integrative modalities. I know they've had pilots. I cannot speak with authority to current coverage, but certainly they've explored covering massage and acupuncture because the evidence base for these modalities is quite compelling. For rehabilitative approaches, depending on coverage, the number of physical therapy or occupational therapy visits may be limited. The American Physical Therapy Association has done a great job of encouraging and supporting expertise in cancer rehabilitation. And with that comes expertise in managing, using physical modalities and exercise, pain in disease-free cancer survivors, as well as those who are in the more palliative stages of disease. And so we have a growing workforce with the capability to serve these patients, yet it's not enough. That continues to be a challenge for some patients, depending on where they live. And as I mentioned, ensuring coverage for an adequate number of treatment sessions is sometimes difficult.
This has been incredibly informative. And before we close, I just want to ask you to speak a little bit specifically about lymphedema. As you're a lymphedema expert, could you tell our audience a bit more about gold standard best practices for lymphedema assessment and management in patients during and after cancer therapy?
Absolutely. As I'm sure the audience is aware, lymphedema is a potential sequelae of cancer treatment. Cancer itself, by infiltrating nodes and disrupting lymph flow, can cause lymphedema. Radiation, taxane chemotherapy, nodal removal to stage cancer and achieve local control all contribute to lymphedema risk, as well as patient sociodemographic factors. Black women are at higher risk of lymphedema. Obesity is linked to development of lymphedema. The science has advanced to a point where we now can engage in risk-directed surveillance practices. If a patient has a low risk of lymphedema, they've had very few lymph nodes removed, or even perhaps none, we don't think their radiation was sufficient to cause damage, we wouldn't surveil them in the same way we would as somebody at higher risk. So there are now a collection of very effective approaches. We use bioimpedance spectroscopy to measure extracellular fluid. And in breast cancer, we have an uninvolved contralateral limb. So that's an ideal situation. And we're able to identify incipient lymphedema in its very earliest stages and initiate treatment, which may be education and precautions, using compression garments in provocative situations, which might be vigorous or repeated use. So we can use bioimpedance. Patient-reported outcome measures assessing symptoms have been shown to be quite sensitive in detecting lymphedema. Circumferential measurements with a tape measure is something that actually patients can get very good at doing on their own, which eliminates the requirement to make yet another trip into a health center. So I'm personally a big advocate of training patients to inspect the body part at risk, and that depends on the type of treatment and which nodal basins may have been affected, but self-inspection and measurement. There are excellent resources out there that provide guidance. Treatment of lymphedema really varies by stage. There are 4 stages by what we call the International Society of Lymphology system. There's a preclinical stage 0, in which there's no appreciable volume difference. Stage 1 is where it's simply interstitial fluid. You don't have any of the biochemical or morphologic changes that we see at the later stages. Stage 2 is distinguished by the formation of subdermal fibrosis or disorganized collagen deposition in the tissue. And then stage 3 is dermal metaplasia. That's the hallmark of stage 3 lymphedema. So treatment very much depends. If it's stage 0, preclinical, probably, as I mentioned, education, a compressing garment. We might up the game in terms of surveillance, having them maybe encourage them to consider something that's more sensitive, like bioimpedance. If it's stage 1, usually that is managed with a sleeve. Exercise is a very effective way of not necessarily reducing lymphedema, but preventing progression. There is now excellent evidence from multiple large, well-powered, randomized clinical trials attesting the benefit of gentle, incremental, resistive exercise. So that would be something we'd encourage. And then once you get into stage 2 and stage 3, treatment often is more what we would call reductive. Initially, we're trying to make an arm smaller because it's now progressed. And so we use bandaging, massage, exercises, skincare, education. In good hands, it can be remarkably effective. We can reduce limbs by 50 to 70%. The problem is treatment at that intensity was not developed in the US. It was developed in Europe, which has a very different coverage system. So it can be a real challenge to ensure that our patients receive the optimal intensity of lymphedema treatment or reductive therapy, we would call it, to optimize their lymphedema.
Does lymphedema tend to cause pain in your experience, Dr. Cheville?
It definitely can. And it's a great question because I think sometimes pain is incorrectly attributed to lymphedema and it may delay workup and diagnosis and treatment. Lymphedema-related pain is virtually always a generalized heaviness, aching. Some patients describe tingling, which seems to be genuinely due to lymphedema. We know that the accumulation of inflammatory mediators in the interstitium can sensitize nociceptors and other nerves. So it doesn't necessarily mean a neuropathic pain syndrome when they describe that, but heaviness, aching, the arm feeling strange, these are some of the adjectives or descriptors that patients will use. And it is distributed in the territory at risk for lymphedema, often occurs after repeated use or vigorous use of the extremity. The treatment is reductive decongestive therapy. What is not lymphedema pain would be focal joint pain, pain that's associated with focal, sensory, or neurologic deficits. One caveat to that is patients with metastatic disease. I most often seen this in breast cancer when the cancer invades the lymphatics, but as well as the brachial plexus. Many times the combination of joint contracture, neurologic deficits in the arm with rapid progression of lymphedema is an indicator of cancer, and that requires a very different approach, obviously.
Certainly. Thank you so much for sharing these incredibly important insights. Today, we've talked to Dr. Cheville about pain management and the role of physical medicine and rehab in addressing root causes of pain during and after cancer treatment. Thank you for tuning in. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on cancer survivorship. This is Dr. Kathryn Ruddy for the Medscape in Discussion Cancer Survivorship podcast.
Thanks for listening to Medscape's In Discussion Cancer Survivorship podcast series with our host, Dr. Kathryn J. Ruddy. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on cancer survivorship.